This panel is on state, local, and tribal views. I'll ask our panelists to be seated.
I think I'm supposed to sit to your left.
Okay.
Thank you for letting Secretary Levitt go first, because he told me he was about to leave to go catch a plane. So
okay.
Levitt goes first. He's a big boss.
Okay. I think we're missing. Are we missing a chair there? Or?
Okay.
The music stopped.
Oh, you're Assemblyman Weber. Yeah, you need a chair.
Can I sneak in here? Yeah.
Oh, is that Alan? Oh, that's.
You make it? Yeah.
I get the chair.
Yeah.
Okay, now let me just warn everyone that you're seated out of order, so I'm not going to ask anybody to change, but I'm going to call members to speak on the order that I have here. So let me introduce everyone. First is Honorable Michael Levitt, who is former Secretary of U.S. Department of Health and Human Services. Thank you for being with us. I know you can't stay the whole time, but then that's fine. We have you first. Second is my good friend, the Honorable Joseph Vitale, who is Chairman of the Committee on Health, Human Services, and Senior Citizens of the New Jersey State Senate. Is actually in his district is in my congressional district, and he's been here before, and we appreciate your coming today, Senator Vitale. And then I have W. Ron Allen, who is the Chairman of the Jamestown Scullum Tribe. I hope I got that correct. And then we have the Honorable Jay Weber, who's a state assemblyman from my state of New Jersey. Welcome. And then is Dr. Raymond C. Shepak, who is Executive Director of the National Governors Association. And we have Robert S. Freeman, who is Deputy Executive Director of CenCal Health, California Association of Health Insuring Organizations. And finally is Ron Pollack, who's Executive Director of Families USA, again, a frequent visitor to this subcommittee. So we will start with Secretary Levitt. Thank you for being here. Well, let me mention again, I think you probably heard it enough times, but 5 minutes, we ask you to speak for 5 minutes, keep it to that. Your written testimony will become part of the record, and of course, after you're finished, we'll have questions from the panel. Secretary Levitt?
Thank you, Mr. Chairman, and thank you for your acknowledgement of my inability to stay the whole time. But I am pleased to be here. My formal statement, I'll summarize it by saying I've listed 10 things in this draft that I believe could be unifying principles. I've listed 10 things that I believe are serious problems and 10 ways I think those could be resolved. So the committee will have access to that, and to the extent that you have questions for me, I'd be happy to respond to them either in writing or later publicly. I was intrigued, however, by conversation in the earlier panel, and I'd like to take my time to respond to the question of Medicare's efficiency. I suspect I am the only, or at least one of the only people in this room who's actually overseen Medicare, and I would like to answer the question as to its relative efficiency, if I could. If the question is does Medicare issue checks on a more efficient basis than anyone else, I think it's important to answer that yes. Medicare issues checks more efficiently than anyone else on the planet, and we should, because Medicare issues about 1 billion of them a year. The problem isn't its administrative efficiency. The problem is what it pays and how it pays it. Medicare has 3 fundamental problems in my assessment. The first I call silo syndrome. Silo syndrome is a function that everything is paid without coordination. So it isn't how efficiently it pays, it's the fact that it pays the wrong things and pays too many things and does not require any level of coordination. If we were to impose on, say, the automobile industry, the process of finance in the healthcare industry, you'd walk into a car dealership and you'd say, I want to buy a car. The dealer would say, we can see you do, pick one out, and we'll send you the bills later. And a few months later or weeks later, you'd get one from the chassis maker, you'd get one from the tire manufacturer, you'd get one from the dashboard people, one from the windshield, and one from the dealer. And the dealer would say you were in the showroom for a while, then you went to the salesman's office, and then there was that $21.97 cup of coffee you thought you were getting because you were thirsty. The point is that if there was a steering wheel that was $800, the manufacturer of the car under the current system would say, we can't afford that because we've got to deliver it for $23,000. In the healthcare system, if the crutches provider in a knee operation says we want $400 for the crutches, we just provide them. There's no coordination. So it's not the fact that we're able to issue checks efficiently. It's that all of the care is siloed and uncoordinated, and that runs up the cost. So it might look like efficiency, I would suggest to you, is not. The second problem with Medicare is that it has what I call chronic more. Everything is oriented to more. And the third point I would say is that it's quality indifferent. So it isn't efficient because it can issue more checks than anyone on the planet. It's inefficient because it's siloed, because it's quality indifferent, and because every incentive leads to more. And I suspect you'll see that reflected in my testimony as to why I oppose and why I hope our country will not go to a public option plan. For us to adopt a system that has moved our country financially toward what I believe will be its most devastating financial crisis, and then put more people in it, is like suggesting that we are going to cure obesity with a perpetual regimen of double calories. That is not the solution. And I've listed in my testimony a series of suggestions on how I believe this bill could be unifying, how the bill could become a bipartisan proposal, and I'm very hopeful that that can occur. This country badly needs for every American to have access to insurance. We desperately need to reform the system, and I hope very much that this will be a moment where we can do so on a bipartisan basis. Thank you.
Thank you, Mr. Secretary. Senator Vitale.
Thank you, Chairman Pallone and members of the committee. I am Joe Vitale, I chair the Senate Health Committee in New Jersey, and pleased to be here again. I know we were here a couple of years ago when we were debating the reauthorization of SCHIP and what it meant to my state and to the millions of parents and children who we are now blessed to cover under that program. I want to highlight some of the sentinel points of New Jersey's journey toward health care reform, as well as my personal view as a state legislator, a leader in health care reform, and as a small business owner as well, to discuss the access to affordable and dependable health care for not just the 1.3 million uninsured New Jerseyans, but the remaining 45-some million Americans. New Jersey has learned many lessons as we grappled with the complexity of reform over the past several years. Our state's reform efforts will benefit from the proposals being discussed here in Washington now. When SCHIP was first adopted in 1998, New Jersey initially offered enrollment for children whose family income did not exceed 200% of the federal poverty level. Shortly thereafter, we increased eligibility to 350% of federal poverty for those kids, recognizing that we needed to do more, that New Jersey was an expensive place to be low income, and we needed to get those kids insured. Those parents couldn't afford the insurance on their own or through their employer. In addition to expanding affordable access for kids, we also began to welcome parents into our program through a waiver by CMS, whose family's income did not exceed 150% of the federal poverty level. These legislative initiatives became the foundation upon which we in New Jersey have begun to build a framework for providing universal, portable, affordable, and sustainable health care access to New Jersey's remaining 1.3 million uninsured. Our efforts began nearly 3 years ago with the formation of a working group comprised of 22 policy experts representing a wide variety of experience and professional background. I believed then, as I do today, that New Jersey could not have enacted our most recent reforms without taking the necessary time to painstakingly understand the complexity of reform's impact on the diverse group of stakeholders healthcare encompasses. Our working group met for 2.5 hours every week, worked on a daily basis with staff to process the input from those sessions, and traveled the country from San Francisco to Chicago, to Washington, to meet with other states actively reforming their systems. We shared the reform efforts each of us were undertaking and met with national policy groups with expertise in healthcare access, quality, cost modeling, efficiency, and insurance reform. It was through those efforts that we were able to offer a thorough and well-planned legislative proposal that enjoyed overwhelming bipartisan support, approval moving from announcement to passage into our law in a short 4 months. Our most recent initiative accomplished much. It increased eligibility for more working parents whose income did not exceed 200% of the federal poverty level. We established a buy-in program for children whose family's income exceeded our SCHIP cap of $350. This program was created after negotiating with 2 of our state's leading health plans who agreed to offer an excellent benefit design at a very low price. This program does not use any state or federal dollars. We implemented a Kids First mandate that required all eligible children to enroll in either a free or a very low-cost health insurance program in our state. It required a Department of Treasury to include a checkoff on all state income taxes, or tax returns that seeks information from filers regarding the health insurance status of household dependents. This provision enabled New Jersey to be the first state in the nation to utilize the express enrollment process approved here in Washington and CHIPRA. It also directed our State Department of Human Services to design a cost-effective and thorough enrollment outreach program and to design a minimum hardship exclusion or premium hardship exclusion that does not allow an enrollee to drop out of coverage, but provides for an income set-aside that can lower their premium to an affordable level, but also maintains them in coverage and not out of coverage. It also instituted a number of reforms to our individual and small employer market that made those policies more affordable while dedicated a larger percentage of collected premiums to the actual provision of care. I'm proud of what we've accomplished in New Jersey. We've been one of the most progressive states in offering expanded access to hundreds of thousands of children and working parents, and we're currently well on our way to our comprehensive and transformational reform. But as you know all too well, states can only do so much. We have limited finances, we have limited political will, and with states having different programs at different levels for children and for parents in some states, it becomes just undependable and unreliable. We in New Jersey, though we're proud of the work we've done and the great steps and strides we've made to ensure hundreds of thousands of kids and many parents in our state, we need the federal government, we need your leadership and leadership of your colleagues and the President to make sure that the remaining 1.3 million who are uninsured today and those who will become uninsured have access to the same kind of health care that we all enjoy, that they'll have the same kind of card that we all have, and in some cases, I know we all take for granted maybe the health care that we do have. But for them, they wake up every day with the fear that they'll get sick, their kids will get sick, they won't have the ability to pay, and a national program that brings together in a large group those millions of Americans who need our help is well justified and well needed. I want to thank you for their effort.
Thank you, Senator, and thank you for waiting, all of you, actually. I know you've been here since early this morning, so I appreciate it. Next is Mr. Allen.
Thank you, Mr. Chairman. My name is Ron Allen. I'm the chair and CEO for the Jamestown S'Klallam Tribe, located up in northwest Washington. And I'm also an officer at the National Congress of American Indians, and my testimony presented to you in the committee is on behalf of our organization that represents and advocates for all Indian nations from Alaska to Florida, representing over 560 Indian nations and communities and 4 million people. As I listen to the dialogue all day today, we find it interesting when we talk about the unmet needs of health care. No one knows that more than Indian country. I was listening to some interesting comments this morning about how America is highly represented in cancer recovery rates and diabetes recovery rates, et cetera. Well, in Indian country, we have the highest level of cancer rates and deaths and diabetes crises and tuberculosis exposure, et cetera, than any other ethnic group, any other sector of our society. And it reflects the incredible unmet needs in our Indian communities. But what we do believe is that this initiative that's being advanced by the Congress and by the administration is an important one. We agree that the idea of addressing reducing costs and providing competent care and affordability and quality is something we all look forward to, and the Indian tribes across America concur that has to happen. We want to remind the Congress, it seems like every time key pieces of legislation that are emerged, that the tribal governments are a part of the American political family, and that we are governments, and that we're very unique in America as governments and as employers, as governments in our businesses that are important to the revenue generation for our essential services, including health care in our communities. And any legislation that is advanced to address such a subject matter as this must include our governments. So we appreciate what is being advanced in all the different components of this proposed bill. But we do want to point out there's a number of issues that we're concerned about, and that we need to, that we would urge you as the committee, as a Congress, to consider these specific conditions that are essential for the services to be provided to the Indian communities because of our unique conditions and how services are provided to the American Indian and Alaskan Native peoples across the nation. We need the legislation to exempt American Indians, Alaskan Natives from mandates and penalties. We need this legislation to exempt tribal governments from the employer penalties. It is essential that the American Indians, Alaskan Natives should be eligible for those insurance subsidies, and that the portability component is also essential for our people as well. Explicitly state that the Indian Health Service and the tribes are essential community providers, so that it's clear that is how the services are being provided. And another key component that we're concerned about is making sure that it is clear that the health care services that are provided to the tribe, to the Indian people, that they are exempt as income. The IRS wants to identify these resources as taxable income, and for the Indian communities, we have paid for it. They're reflected in our treaties, in the commitments of this nation. This nation is great because of the commitment of the Indian communities across the nation, and so therefore that as prepaid health care, they should not be taxed for services that have been long overdue from this nation to our communities. So these aren't just a wish list. They're critically important to make it effective to fulfill what we believe is the unmet need for our communities, consistent with a lot of sectors of America. The Health Care Improvement Act is important, and it does need to be passed and addressed, but it is not, this does not replace that bill, that legislation. That is a fundamental for Indian country, as is so important for all of us. There are many other points I could address, but I think that I've highlighted the main issues. Our testimony has identified a long list of issues and recommendations that we have made to you, and we look forward to working with you, the committee members and the staff and the President on making this happen to raise the level of health care for all people, including American Indians and Alaskan Natives. Thank you, Mr. Chair.
Thank you, Mr. Allen. Next is Assemblyman Weber. Thank you for being here as well.
Thank you, Chairman, and I'd like to thank the committee for the invitation. My name is Jay Weber. I represent the 26th Legislative District in the New Jersey State Assembly. I'm here, actually, and like Senator Vitale, I think we both take great pride in our state, but we have different views of the state of health care in our state. And one of the reasons that we are in such desperate need of reform in New Jersey is some of the things that we've done in the past. My message to the committee, if I can leave one, is please don't do to the nation what New Jersey has done to itself. We embarked on a series of reforms in 1992 with the intent of improving access to health care and health care insurance for our citizens. Many of the policies we put in place have been discussed already in the committee today. Things like guaranteed issue, community rating. There were a series of mandated coverages that have continued to be piled on, and even as late as recently as this year, the legislature and the governor raised the minimum loss ratios for insurance companies in our small employer and individual markets. These reforms, so-called, have created what I would call a toxic mix for destroying the health insurance market in the state. Actually, one commentator called New Jersey the poster child for how to destroy a health insurance market. And the results have been rather predictable. Costs for health insurance in New Jersey have skyrocketed to the point where today the average premium for families on the individual market is as much as twice the national average. Small employers find themselves not being able to afford to provide insurance to their employees anymore, and consumers have fewer choices as fewer insurance companies write policies in the state. The reforms in 1992 did not result in a reduction in the number of uninsured, quite the contrary, whereas in 1992 we had 13.9% of our population uninsured. After these reforms, the uninsured population stands today at about 15.8%. I have a lot more statistics in my written testimony to the subcommittee, but there's one story I'd like to relate to you, and a constituent wrote into me just after the bill that Senator Vitale discussed earlier, just after that bill was passed. A man named Fred is a CPA. His wife is quite ill with a lot of doctor's bills, very content with his coverage that his employer was able to provide him. But after the bill that the senator discussed was passed and the minimum loss ratios were put into place, the insurance company stopped writing insurance in New Jersey, and Fred lost his insurance coverage. His employer could no longer afford to purchase it. There are stories like that being played out across the state as our attempts to reform the system wind up doing more harm than good. There are solutions that I advocate vigorously, and many members of the legislature do advocate in New Jersey. The most prominent of which would be to allow New Jerseyans to purchase health insurance across state lines. Increasing competition and consumer choice will provide less expensive and higher quality health care to New Jerseyans. It will lower their premiums. And one study by University of Minnesota economists estimated that as many as 700,000 New Jerseyans would be able to afford to buy health insurance if they simply were allowed to purchase health insurance across state lines. That's 700,000, or almost 50% of the uninsured population in the state, wiped off the uninsured rolls without spending a taxpayer dime. I think that's a significant reform that we should try. There's great enthusiasm for that measure, and I've gotten unsolicited letters and emails all across the state, not just from constituents in my district, urging the legislature to go forward with it. I just think it's no longer acceptable to trap New Jerseyans in a state and in a system that they want to leave. We have New Jerseyans who are looking to purchase health insurance out of state, would do it if they could, and insurers who would sell them insurance if they were allowed to come in and sell policies free of the underwriting rules and the coverage mandates that New Jersey puts on them. But we stand in their way with regulations and laws that block those transactions. I discussed with a colleague of mine on the floor of the Assembly why they opposed the Healthcare Choice Act that I've sponsored in New Jersey, and the answer was quite simple, and it was rather disturbing. And the answer that I got was, we need their lives. We can't have New Jerseyans who would buy cheaper health insurance across state lines who might be uninsured today. We can't have them leaving the state because we want to do single payer, and we need their lives to subsidize the sicker and the older in the state. I disagree with that approach, and it's disturbing to me that after more than 20 years after Ronald Reagan went to the Brandenburg Gate and told the Soviet Union to tear down that wall in Berlin, that New Jersey continues to put up walls to trap its citizens in a system that is failing them and that they want to leave. So if that's the enduring lesson that I can bring to you today, that's what I'm trying to do. Again, I would respectfully request that the members of the committee and Congress not repeat the mistakes that New Jersey has made on a national level. Thank you, Mr. Chairman.
Thank you, Assemblyman. Dr. Shapak, I had to ask how to pronounce it.
Thank you, Mr. Chairman. I appreciate the opportunity to appear before you today on behalf of the nation's governors. I will very quickly focus on 6 issues. The first is respect to the insurance reforms. Although we agree that the federal government probably should set the market rules with respect to guaranteed issue and renewability, We think the rate bands in the bill are too narrow. They should be broader so that states had the ability to go above those particular minimums. We're also very concerned that a lot of the state insurance reform is being preempted essentially by the Health Choice administration in the bill. We think that states do a relatively good job of protecting consumers, but we think that the bill is going to add a lot of confusion with respect to who does regulation and who does enforcement. Is it the state? Is it the Department of Labor? Is it the independent agency or the Department of Human Services? Finally, I think there's going to be a real challenge in setting market rules outside the exchange to be consistent with the ones in the exchange, because different rules would likely perpetuate the risk selection and fragmentation that exists in the marketplace today. With respect to the health insurance exchanges, it seems that the draft bill creates a super independent agency, the Health Choices Administration, to make just about every decision with respect to exchanges. There does not seem to be any clear advantage for states to design and administer the exchanges, and yet they have the expertise and capability, and I think it's very important that the other subsidized population needs to be well coordinated with Medicaid. The bottom line is, given the rigidity of the administrative rules here, I question at this time whether a substantial number of states would actually opt in to the system. With respect to the Medicaid expansion, while governors differ somewhat on the Medicaid expansion, my sense is that they would question the necessity of increasing the eligibility of childless adults and parents over 100% of poverty. It seems that these individuals could be made directly eligible for the other subsidy and receive their benefits through the exchange. Governors do, however, very much appreciate the fact that the committee is willing to have the federal government pay 100% of the expansion. The phased-in mandate to increase reimbursement rates for primary care physician gives states pause, but we do realize that it is a very, very small percentage of the total reimbursement rate. Governors do support the choice for individuals to move out of Medicaid into the exchange. However, we would not support requiring states to provide the wraparound benefit. This would also include the CHIP population. The problem is that the wraparound benefit is administratively difficult, and maintaining the additional benefits may weaken the negotiating power of the exchange in receiving the most competitive prices. With respect to the dual eligibles, there's a number of provisions in the bill that we do think strengthen the integration of the dual eligibles, so governors are generally supportive of those provisions. And also with respect to the drug benefit rebates and a number of the provisions there, governors support that as well. Just one final comment on the transition, that if and when this bill passes, it's going to be a huge implementation role for states and others, and therefore I think that the bill should include specific provisions about some upfront money for states to build capacity to implement, as well as certain certifications when the insurance reforms are done and when other components are willing to be administered. Clearly, you've got to coordinate the individual mandate, the other subsidized population, as well as the employer mandate in the bill. Thank you for the opportunity to testify. I look forward to working with the committee as you move the bill forward.
Thank you. Mr. Freeman.
Mr. Chairman, members of the committee, my name is Robert Freeman, and I'm here to represent 5 publicly run health plans that administer the Medicaid, S-CHIP, and other programs for low-income individuals. We currently serve 9 and soon to be 11 California counties, and our group is the California Association of Health Insuring Organizations. Today, I hope to provide a local perspective of what is currently being accomplished by our publicly sponsored health plans in California. I do so in the hopes that it may serve this committee as it addresses the massive task of national health care reform. I'd like to briefly describe how our health plans operate. I hope that it will further discussion by policymakers in relation to the healthcare delivery administration at the local level in addition to the state and national level. County organized health systems are one of two public plan models in California, and we've been in existence for over 25 years. My plan, CenCal Health, was the first, beginning operations in 1983. Since that time, 4 other county organized health systems have been established in California and 1 in Minnesota. These 5 plans have built on our success and will soon be effectively providing access to high-quality health care to over 880,000 individuals. That is larger than 25 state Medicaid programs. Our governing boards consist of local government officials, physicians, hospital administrators, plan members, and other health providers. We are independent of county government and function as a business. Although we are public entities, we have no guarantee of perpetuity. So like a business, if we don't do our jobs well, we can go away. We also operate full risk contracts with the state of California, necessitating efficiency and innovation. We are cost effective in relation to CenCal Health. 92 cents out of every dollar goes to the direct provision of health care services. Further, the California Legislative Analyst, which is similar to the Congressional Budget Office, has stated that county organized health systems annually save the state of California $150 million over what it would otherwise spend on its Medicaid program. As public entities, all governing board meetings are public and board decisions are made in an open and transparent environment. Our plans also have broad-based provider networks. We found the policy of broad-based provider networks to be very effective in both providing member choice and building community support. Speaking of my own plan, we have approximately 90,000 members and have 289 primary care physicians, 1,200 specialists, 9 hospitals, and 113 pharmacies to serve our population in 2 counties. We also believe that our broad-based provider policies have contributed to the high quality of care we provide to our members. The state of California has a series of indicators that annually measures to assess access to care and quality of care levels, mostly preventive. County organized health systems are consistently high performers in relation to these measures. We also score well in biannual consumer satisfaction surveys. With this in mind, we believe that the public health plan concept currently works at the local level in relation to our plans. Further, in relation to the S-CHIP program in California, public plans compete with private plans effectively and fairly, with neither private nor public model working from a disadvantage. In the areas of Medicaid expansion and creating vehicles to serve currently uninsured, we're in favor of both concepts. Expanding the Medicaid program is an existing means to provide health coverage to currently uninsured individuals. The infrastructure to provide needed care already exists, as do significant state and federal standards, requirements, and regulations to protect members, providers, and others. The health insurance exchange concept outlined in the draft legislation seeks to create a fair and reasonable means of providing access to care and quality of care and choice. We do suggest that extra care be given to ensure the development of a health exchange will do no harm to existing health care programs and safety nets in our communities that currently work well. Our association believes the transparency provisions in the draft legislation are essential to build and maintain public trust in the delivery system. I'll conclude my remarks by requesting the committee to take a good look at local delivery of health care options in relation to national health care reform. We believe including such a local component would promote community involvement, investment, and enthusiasm in national health care delivery. Yes, all health care's delivery is local. Thank you for your time.
Thank you, Mr. Freeman. Mr. Pollack.
Thank you, Mr. Chairman. Thank you and members of the committee for your prodigious patience. Very much appreciate it. And I want to thank you for the draft bill that has been offered. We think it goes in the right direction for a number of reasons. I was asked by the staff to focus my remarks on the changes with respect to the Medicaid program, and so I will focus my comments on that. As you know, Medicaid provides coverage today for almost 60 million low-income people, approximately half of whom are children. And we think that Medicaid is the right vehicle to provide coverage for the poor. Medicaid provides certain things that simply don't exist today in the private marketplace that I think are absolutely critical for low-income populations. A recent article in Health Affairs pinpointed how important it is to provide cost-sharing protections for low-income people, and if they don't have those cost-sharing protections, means they're unlikely to get the services that they need. Well, Medicaid rises to that challenge. Medicaid does not require premiums or enrollment fees. Co-payments for individual services are limited normally to nominal amounts. Certain kinds of services are exempt from cost sharing, things like preventive care for children, emergency services, pregnancy-related services, and certain populations also are exempted from cost sharing. Foster children, hospice patients, women in Medicaid breast or cervical programs. These are very important protections that simply do not exist in the private sector. But over and above that, Medicaid provides certain kinds of services. For example, for children, early and periodic screening, diagnosis, and treatment is very important so that children get preventive care, and any diagnosis that shows that something needs to be taken care of does get treated. Transportation is provided to doctors' offices for appointments and to community health centers. There are appeals rights that are very important that do not exist in any similar robust fashion in the private sector. There aren't insurance market problems like you have in the private sector, kinds of problems that would be corrected over time with the bill that you've introduced. Medicaid provides good health outcomes. As the Kaiser Commission on Medicaid and the Uninsured reported in May of this year, those in Medicaid are less likely to lack a usual source of care. Obviously, that's true compared to the uninsured, but it's also true compared to those with private insurance. They're more likely to have a doctor's appointment in the last year. They do not have an unmet health need with the same frequency as those who are uninsured and those who have private insurance. Low-income women are more likely to have a Pap test in the past 2 years. So Medicaid does provide very significant services for this important population. And it does so while costing approximately 20% less to cover people in Medicaid than it would cost if they purchase coverage in the private market. Now, building on Medicaid and strengthening the eligibility standards is something that I believe is close to consensus agreement. There was huge support for this from the various stakeholders, American Health Insurance Plans, Blue Cross Blue Shield, American Medical Association, American Hospital Association, AARP, NFIB, Chamber of Commerce, Business Roundtable. We all reached agreement about the importance of doing this. And one of your favored colleagues of the past, Billy Tozan, and we at Families USA have agreed that it's very important to extend eligibility, as this draft bill does, to 133% of the federal poverty level. So I want to concentrate on why I think that measure is so important. We have huge differences today between different populations, children, their parents, and other adults who do not have dependent children. For children, due to the confluence of the Children's Health Insurance Program and Medicaid in almost every state, children are eligible for coverage if their income standards are below, family standards below 200% of poverty. And in some states, as you know, Mr. Chairman, some states have exceeded that. However, for parents, in only 16 states and the District of Columbia does the eligibility standard even reach the federal poverty level, which, mind you, for a family of 3 is only $18,310. Indeed, the median income eligibility standard among the 50 states, as you'll see in the chart at the end of my testimony, is only 67% of the federal poverty level, roughly $12,300 for a family of 3.
Mr. Pollack, you're a minute over. If you could summarize.
I would just say I think this would be very helpful. if we did extend eligibility irrespective of family status, and I'm glad that the committee appears to want to go in that direction and pay for those costs. Thank you.
Thank you, and I want to thank all of the panelists. Now